moving on to a snippet of some of the procedures that we perform commonly in sort of no particular order. For overactive bladder or patients with urinary urgency frequency with or without urinary incontinence, we will often offer them a procedure where we inject Botox or muscle paralytic into the bladder using this needle. We inject usually in 20 different spots to help paralyze or relax the muscles in the bladder to prevent bladder contractions that lead to urinary frequency and potentially leakage. For patients with stress incontinence, this is urinary leakage with cough, laugh, or sneeze. We will sometimes offer them a procedure called urethral bulking, where we inject a bulking agent into the sort of inner part of the bladder neck or the urethra. We do this by putting a camera in the bladder. A little needle comes off the end of the camera, and the needle's connected to this bulking agent that we inject slowly into 3 different areas of the urethra. And the goal is to narrow the opening of the urethra in order to decrease the amount of leakage a patient has. Pessaries are a non-surgical option. It's not necessarily a procedure. It's done in the clinic without anesthesia. The patient has to be fit for the appropriate pessary. You can see there are different pessaries. This is a ring pessary. A Gellhorn has a little knob on it. This is a ring pessary with knob also. It's a slightly different type of pessary for incontinence specifically. But these are office procedures that we do without anesthesia. The gold standard treatment for stress incontinence or leakage with cough, laugh, and sneeze is called the midurethral sling. There are different types of slings. The most commonly performed sling is this, well, it depends kind of where you are in the country, but the retropubic sling and the TOT or the transobturator sling are the most common. This is done with a little 1 centimeter incision in the vagina, and then we tunnel up the 2 ends of the sling on each side of the bladder. This is done in either the ASC or the hospital. This is an outpatient procedure. It's about 20 minutes, and it's about 90% effective, so it works quite well. For prolapse, which as you can see here, this is the uterus sort of coming down, there are numerous different types of procedures, but one of them that you'll hear a lot is called the Sacroculpopexy. I'm actually going to scroll back quickly to a better view of what this procedure actually entails. So this is a picture here again of this prolapsed uterus. The uterus is removed, and you can see this white kind of structure here. This is mesh. You can see it's shaped like a Y. It's kind of like an upside down Y. We attach the front part of the mesh to the vagina and the back part of the mesh also to the vagina, and just lift the vagina up and connect this to a ligament on the tailbone. It's the strongest ligament in the body. But this is an effective procedure for patients who have profound prolapse, and even, not necessarily profound prolapse, but symptomatic prolapse, such that they want a repair that will kind of last the longest. But aside from using mesh, there are lots of different ways to lift up prolapse. Again, it depends on where the prolapse is. We don't have to use mesh. We can do procedures all through the vagina. So there's probably 6 or 7 different types of procedures that we can do for prolapse. Okay, thank you so much for listening, and have a great day.